So today's video is about febrile seizure and very important topic and high yield topic regarding certain exams. So febrile seizure is defined as a seizure that fulfills the following criteria. So criteria number one, that age is between 6 months and 6 years. Some references said 6 months to 5 years, but most of the references say that from 6 months to 6 years. And if the temperature is between is about 38 degrees centigrade, that is 100.4 Fahrenheit, and there is no CNS infection and metabolic cause that could cause the seizure, and the other criteria that should be met, that there will be no prior history of any febrile seizure. So if these four criteria are met, then we can say the child that presented to you is having febrile seizure. Uh, the spectrum of febrile seizure is either simple febrile seizure or complex febrile seizure, or sometimes we call it febrile status epilepticus. So generalized, as we say, the generalized simple febrile seizure will be generalized. They will be lasting less than 15 minutes, and they will not reoccur within 24 hours. On contrary, complex febrile seizure will be focal. They will be more than 15 minutes, and they will be recurring within 24 hours. So, and febrile status epilepticus is any seizure that lasting that present with the fever and last for more than 30 minutes. Say so, will be labeled as febrile status epilepticus. But if you study literature, now they say that any seizure that is lasting for more than 5 minutes, it kind of becomes self-sustained seizure. So you can call it a febrile status epilepticus. But the cutoff is like you can intervene here and start treating a seizure as a status if it lasts more than 5 minutes. One thing of note is the two syndrome, that is generalized epilepsy with febrile seizure plus. This we call generalized epilepsy with febrile seizure plus. It's a epilepsy syndrome, and there is another syndrome that is called Dravet syndrome. So these two syndrome, they may initially present with febrile seizure, but they then will be ongoing, and they will be presenting with an epileptic like syndrome. So uh, the seizure, the febrile seizure that presented to you may be a start point for such syndromes. Risk factors, so high fever has been noted to be one of the risk factors for febrile seizure. Viral infection, more than bacterial infection, and bacterial otitis media or acute otitis media is one cause. Viral infection, the top, like human herpes virus 6 and influenza virus are implicated to be the top two causes. Immunization such as DTP or MMR vaccine cause high-grade fever, and that could be causing uh, febrile seizure. Genetic susceptibility is another very important. That's why we can see a family history is so important. And autosomal dominant inheritance and polygenic inheritance has been implicated in febrile seizures. And these there is a specific, so for learning point and for exam point, hippocampal abnormality has been seen, and in these patients who are genetically susceptible to have febrile seizure. So whenever you see a patient of febrile seizure, you start with a history and you look for what was the characteristic, what was the duration of the seizure, any underlying neurological abnormality, any family history of the seizure, what is the vaccination status of the child, uh, uh, any finding. We do a thorough neurological exam. You start with, if the child has an open AF, you examine the AF, you look for vitals. You begin with the vitals, and then you look for AF, eye examination, you do tone power in upper and lower limb, you look for the meningeal sign of meningeal irritation. So you perform a thorough physical exam. Then we go next to the how you investigate, is a lumbar puncture indicated? So yes, if there are sign of meningitis, if the child is below 6 months, or if he or she is between 6 to 12 months, but the status of immunization is unknown for Haemophilus influenza and streptococcus, or the child is unvaccinated. Antibiotics given prior to seizure to rule out partially treated meningitis is one of the indication for lumbar puncture, and febrile status epilepticus, because most of the time febrile status epilepticus will be caused by pyogenic meningitis. Okay, so routinely we don't perform, but if these risk factors are present, then yes, you can perform a lumbar puncture. Okay, next is any other blood investigation. Yes, if you're performing a blood lumbar puncture, you can perform the full blood count and baseline investigation, otherwise not indicated. If you see the child is dehydrated, you can do a urine procatones, and similarly your urea and electrolytes and hyponatremia. It is considered to be more of risk of recurrence if the child is hyponatremic at presentation, blood glucose level, and if there is a history of decreased oral intake or prolonged fasting in the child. What is the role of EEG? So not indicated routinely, or indicated if there is a high risk of for epilepsy, or there are persistent abnormal neurologic exam, specifically in background of focal seizure, or there is sign of so abnormal neurologic exams and high risk for epilepsy. These two are the top. But what is the optimal timing? So they say in febrile status epilepticus, we call it FES, it is less than 72 hours, and this could predict the future uh, epilepsy. However, and non-specific changes may be present up to, and it may persist up to 10 to 14 days, and therefore EEG, both sleep and awake, should be performed, and it should be performed after 2 weeks. Uh, so it is kind of help in type of epilepsy the child will have, if it can predict that, or type of seizure, but it has very low threshold for future recurrences. Imaging like CT or MRI, they are only recommended if there is neurological abnormality, as I said previously, in background of focal neurological deficits and focal seizure, abnormally large-headed presentation, and sign of raised ICP. So then you can perform, and most of the time you will see a hippocampal swelling and acute presentation, and hippocampal atrophy as a long-term imaging finding. Genetic studies are not indicated, but as I said earlier, the two syndrome, the Dravet, and the febrile, generalized febrile epilepsy with febrile seizure plus, then they have genetic implication, and you can do genetic testing on those conditions. So what is the acute or abortive therapy? So if the IV line is present, you can give lorazepam 0.05 to zero point 0.1 milligram, or diazepam 0.1 to zero point 0.2 milligram per kg. If no, then you can either go with buccal or nasal midazolam. Usually 0.2 milligram per kg is the dose. Uh, Maximum is 10 milligram per kg. Sorry, 10 milligram maximum total dose. If there is no, if that's not available, then you can go with rectal diazepam. If the seizure is frequently recurring, if the seizure is frequently recurring, so we can give like intermittent antiepileptic therapy, like with diazepam, 0.3 milligram per kg per dose, TDS dosing until fever settles. Iron deficiency has been seen in connection with febrile seizures, so iron deficiency should be corrected. This therapy is very controversial here. So phenobarb, lorazepam, or diazepam are usual for intermittent therapy, but they are not routinely indicated because of the benign nature of febrile seizure. Prognosis, so risk of recurrences, there are three major risk factors, that is age less than 1 year, if the child have a seizure and his fever is total duration is less than 24 hours, and the fever is a low-grade fever, then he or she is likely to have a recurrent seizure. Minor criteria: family history of febrile seizure, family history of epilepsy, complex febrile seizure, and the child attends a daycare, the sex of the child is male, or if sodium is low at presentation. So these are minor risks for a recurrence. Risk for future epilepsy. So the highest being is neurodevelopmental abnormality. So if a child with febrile seizure has neurodevelopmental abnormality, so you can predict that there is a 33% chance that he will be epileptic in future. And similarly, focal complex febrile seizure, the second highest, 29%, and then family history of illness. So these three are the top. Similarly, if the fever is less than 1 hour before febrile seizure, this is again one major large number of children will have epilepsy in future. Other minor risks are is if this child have a simple febrile seizure, there's likelihood of epilepsy in future is just 1%. Recurrent febrile seizure is another risk factor, or complex febrile seizure lasting for more than 15 minutes or recurrent within 24 hours usually carries about 6% of the risk. Thank you so much.